Dr. Alfonso, thank you so much for meeting with us today. You had a presentation at AAO 2016, What to Do About Antibiotic Resistance in the Setting of Bacterial Keratitis. Can you give us the main points of your talk?
Sure. So when we talk about antibiotic resistance in bacterial keratitis, it's a very important health care issue. Why? Because many of the patients that develop, for example, the most common form of bacterial keratitis, which are contact lens wearers, over 1 million of those are going to have an infection that does not respond well to the currently available antibiotics. So we need to figure out why this is happening. When we look at the microorganisms involved in bacterial keratitis, approximately 75% are going to be bacteria, 25% are going to be other microorganisms like fungi, parasites, and viral. And in this 75% that potentially is bacterial, in about 50%, if we do cultures, we're not going to be able to identify a bacteria in the culture. So most of the treatment that is applied today to these diseases is based on empiric therapy, meaning that we treat not knowing what we're really treating in terms of microorganism. If they don't respond well, we have to figure out why. When we've looked at the data that I presented, most of these that don't respond, if they're bacterial, is because they are due to bacteria that are not sensitive to the currently available commercial antibiotics. So what are these classes of bacteria? The most common one is Staphylococci, and both Staphylococci, both aureus and epidermidis, are the two that could potentially be non-responsive or resistant. And the resistant group tends to be more methicillin resistant groups. So we need to look for an antibiotic alternative, because otherwise we can't cure them. The alternative is to use a very potent antibiotic, vancomycin, that helps treat the methicillin resistant Staph aureus and Staph epidermidis. But vancomycin is not available commercially, as we know, so we have to extemporaneously make it up in a pharmacy. But if it's a site-threatening infection, my recommendation is that in addition to the commercially available fluoroquinolone, that also a vancomycin be added as a topical drop in order to quickly control the infection and avoid further loss of vision. The other issues that come up often is, well, what if you've done that and still the patient is not responding? Then you have to think of the possibility that this is not a bacteria and that you're dealing with that other 25% of cases that are due to fungi, parasites, and viruses. And so you need to really rely on the microbiology laboratory by doing cultures and coming up with what's the potential other organism that you're now going to have to treat differently. There are newer treatments that are in the horizon that may treat both bacteria and some of these other pathogens, like crosslinking, and potentially some biologicals that are being tested to see if they will help decrease the burden of disease in corneal ulcers. So looking forward to some of these newer treatments and how they can be part of the armamentarium for treating corneal ulcers.